Okay, I think we'll get started. Good morning, everybody. Thank you so much for getting up early to join us. Welcome to today's, sorry, it's early for me too. Welcome to today's breakfast webinar, Highlights and Implications of the Ontario Science Table's Brief on Primary Care. We normally do these at lunchtime and we call them lunch and learns, even though we've never once provided any lunch. So I've decided to call this one our inaugural Bring Your Own Breakfast webinar for a little bit more truth in advertising. Anyway, thank you all for getting up early to be here today. As you know, the Ontario COVID-19 Science Table completed its work last month. It ended with a three-part brief on primary care, which was published on October 3rd. The three chapters of this brief were the roles of primary care clinicians and practices in the first 2 years of the COVID-19 pandemic in Ontario, factors affecting primary care capacity in Ontario for pandemic response and recovery, and lessons learned for strengthened primary care in the next phase of the COVID-19 pandemic. We're joined today by a panel of three of the authors of that report, actually two of them, whom I'll introduce in a moment. They'll present some highlights from that report and what those lessons mean for the future of primary healthcare as the foundation of Ontario's health system. First, I'll go over some quick housekeeping, and then we'll pause together for a land acknowledgement. So the housekeeping will be quick because most of you are Zoom professionals by now. The webinar is being recorded and we will share the link to the recording along with the slide deck later this afternoon or tomorrow morning. So watch your email for that. There'll be a Q&A and discussion period at the end. So please submit your questions in the Q&A panel. And I've set it so that you can upvote each other's and comment on each other's questions as well. Feel free to start typing your questions at any time as soon as you think of them, and then we'll ask them on your behalf and do our best to group them thematically. But if you'd prefer to ask your question out loud, you can use the raise hand function, and then we'll unmute you and call on you. And please remember to remute yourself afterwards so we can keep background noise to a minimum. Now, I'd like to get us started in a good way by acknowledging the original stewards of the land where we are virtually gathering today. We recognize that the work of the Alliance for Healthier Communities and our members takes place across what is now called Ontario, on traditional territories of Indigenous people. They've lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant and diverse Indigenous communities who have distinct and specific histories, needs, and assets, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding our responsibilities to all who now live on these lands, the land itself, and the resources that make our lives possible. My name is Catherine, and I am a settler here. I live and work on the traditional territories of Anishinaabe, Wendat, Haudenosaunee, and most recently the Mississauga peoples in what is now called Toronto. And now I'll introduce our panelists. They're all experts in public health and primary health care. Iman Bayoumi, who unfortunately can't join us today, is a family physician and clinician researcher at Queen's University Department of Family Medicine. She holds the Graham Farquharson Knowledge Translation Fellowship and is an adjunct scientist at ICES, old habits. Her research addresses equity-oriented primary care, including interventions to address child health inequities and health services for individuals experiencing structural inequities. Dr. Bayoumi was a member of the Ontario COVID-19 Science Advisory Table. Danielle Martin is an active family physician whose clinical work has ranged from comprehensive family medicine in rural and remote communities to maternity care. She is a dedicated educator, mentor, and role model to learners aspiring to enter medicine and healthcare leadership. Dr. Martin is a respected leader in Canadian medicine and well-recognized media spokesperson. Dr. Martin was also a member of the Ontario COVID-19 Science Advisory Table. and Jennifer Rayner. Most of you know Jen. She's the Director of Research and Evaluation at the Alliance for Healthier Communities. She has a PhD in epidemiology and biostatistics and is an adjunct research professor at the Center for Studies in Family Medicine at Western and the University of Toronto in the in the Department of Family and Community Medicine with the Institute of Health Policy, Management and Evaluation. She has worked within the community health center sector for over 20 years and is interested in comprehensive primary healthcare, interprofessional teams, and health equity. Dr. Rayner was an advisor to the Ontario COVID-19 Science Advisory Table. Unfortunately, as mentioned, Iman is unable to join us today due to illness, so Jen and Danielle will be speaking to her slides. And with that, I will turn you over to Danielle. Danielle, the floor is yours.
Thanks so much, Catherine. Thank you for inviting us to join you all this morning. And we're really looking forward to some interaction and discussion about the future of primary care, primary health care in Ontario. Just to set the stage, neither Jen nor I think can claim to be an official member of the COVID-19 Science Advisory Table, but rather we were core authors of the three-part brief that was published early in the fall, which was the last brief produced by the COVID-19 Science Table before it was sunsetted. And this brief is a pretty weighty piece of work that involved dozens of people, including many colleagues from community health centers across Ontario, an interprofessional team of primary healthcare experts and researchers. And what we really wanted to do was to try to elevate the narrative of what primary care and primary health care have been doing in this pandemic in Ontario, and what the lessons learned are as we head into the next subsequent waves and phases of the pandemic, and of course, into pandemic recovery. And so what we're going to try to do today is to summarize at a very high level some of the key elements of what was in those briefs for those who may not have had a chance to read them, and to engage with all of you in a conversation about what next for primary care during what can only be characterized as a very challenging time for all those of us who believe in and support and work at the front lines of primary health care. So these are the three briefs, and for those who have whose interest is piqued by this presentation, we'd invite you to visit the COVID-19 Science Advisory Table website, where you can find the full text as well as all the references and a complete list of authors of all three parts of the brief. And just to acknowledge that this is not mine nor Jen's work alone. We collaborated with a broad range of experts from across the province, including, I think, perhaps even some who are on this Zoom call today. So thanks to all those who engaged. It was a heavy lift over the summer months for many of us. Just a couple of words about the methodology, and I won't get into this in any depth, but we want to assure all of you that this was a very rigorous process that we undertook that included looking at the peer-reviewed literature, at the gray literature, and talking to people about their lived experiences of working at the front lines of primary care in the pandemic in Ontario, as well as speaking with experts who were engaged in a wide variety of different roles across the primary healthcare sector. And so, of course, there's a dearth of data in primary care. We're going to talk about that a little bit. And so there are some places where we couldn't speak to evidence with any confidence, but we did do our best to try to be comprehensive in our approach. So the conversation that we hear still, even today, during this moment of fall surge of respiratory illness, about in the media and in the halls of government across the province about the pandemic, really tend to focus on hospitals. And one of the most important messages of this science table brief is why we should care about primary care. Why does it matter? And why should policymakers be paying attention? This slide speaks to what we call the ecology of care, a concept that's been since the 1960s, and even earlier, observed in health systems all over the world, which is that every day, we spend a lot of time, effort, energy, and money focusing on a tiny number of people who are admitted to hospital, who have surgery, or who have an interaction with a specialist. But in fact, for every one of those highly specialized interactions, tens and hundreds of thousands of people are interacting with primary healthcare in its various forms, and even larger numbers of people, of course, are not interacting with the health system at all, including people who one might wish or hope could have an interaction with the health system because they have a chronic illness or some health or social need that remains unmet. And so primary care really offers a critical entry point into the health system, and we are mostly going to be talking about primary care and frontline service delivery of healthcare services during this talk, because that's where most of the evidence is. But where we could, we've done our best to speak to primary healthcare more broadly, including action on the social determinants of health. So this is important also because for every person who's admitted to the hospital with COVID-19 or any respiratory illness for that matter today during this surge, there are hundreds and hundreds and hundreds and hundreds of people who are being seen in primary care for those same issues and concerns. So the point here is just to drive home that COVID-19 is a community-based illness. Indeed, it has always been a community-based illness, and we are grateful that today, with a highly vaccinated population, it is even more a community-based illness than it was, and that COVID care, the vast majority of COVID care in Ontario has been and will be taking place in primary care, as well as care for illnesses like long COVID, for mental health issues that have been exacerbated in the pandemic, for the management of chronic illness, and for all of our colleagues here in the CHC sector, of course, working at the intersection of social determinants and health concerns. So primary care matters because it's where most of the action is in health systems, something that one might forget if only reading the headlines in the papers today. So what did primary care providers do in the pandemic in Ontario? This slide speaks to the many, many roles that are documented in the literature and in people's experiences of work, and really highlights the degree to which all those of us who work in primary care have had to learn new skills and change our daily work. Everything from assessment and, of course, testing for COVID-19 to vaccine counseling and delivery, to the prescribing of therapeutics, including Paxlovid, to the treatment of COVID both acutely and in its ongoing long COVID state, the continuation of care for non-COVID concerns, the support for mental health services, and the list goes on. So really just wanting to acknowledge that this is a huge amount of new stuff that people in primary care have been doing since the advent of COVID-19, and that almost all of this was done without additional resources. And we're going to get to why that matters later in the presentation, but obviously it's not possible to layer on this much new work without seeing trade-offs in other places, and that is indeed what we saw.
So we're going to talk a little bit about how much primary care was actually working, because I think there was a bit of a myth. So some of these briefs just dispelled a bunch of myths that were out there. So how much were family physicians actually working? This chart shows that primary care visits over time by type of visit. So we've started the chart in January 2019, and you can see the dramatic drop in visits at the office in March 2020 and the rapid uptake of virtual visits. So the light blue line represents the total of virtual and office visits, and you can see that the count of primary care visits rebounded by the fall of 2020 for the population as a whole. But you can see much more virtual visits when COVID rates were higher. So some of the shifts we saw early on in the pandemic were driven in large parts by factors beyond the physician's control, including directives from the Chief Medical Officer of Health to defer or delay non-essential care. We struggled with getting PPE to supply and operate offices, and decreased patient demand. What primary care was seeing was that patients were actually not booking appointments because they were sheltering in place. So this graph looks at total days worked by family physicians. Now, when I'm talking about family physicians, just a bit of a disclaimer, and we're going to get to this later about the absence of some parts of data. So we could probably superimpose nurse practitioners to the same graphs, but we just didn't have that data. So this graph looks at total days worked by family physicians in various models. And the charts again start in 2017, so we have some comparison. And you can see in all primary care models an uptick in 2020, reflecting that primary care clinicians worked more days on average to accommodate COVID care, in addition to the regular care provided by primary care providers. And so COVID care refers to management of COVID-related care in both offices and vaccination clinics and assessment clinics, what they did in emergency rooms and long-term care. So this is also consistent with our findings that COVID assessment and vaccinations were done by many primary care providers, but most often outside of the office. So we're going to do a bit of a deep dive into how virtual care transitioned during the pandemic, which of course caused many of our primary care offices and primary care providers to really catapult into this mode of care delivery super fast. Virtual consultations and remote monitoring became widespread in primary care. Again, as I said before, this was driven by a need to reduce physical contact. New billing codes were put in place that actually allowed this to happen, and infrastructure investments. So in the first 4 months of the pandemic, virtual care comprised 71.1% of primary care physician visits. Now, these were overwhelmingly done by telephone. We saw in the data that higher rates of virtual care were directly correlated with higher COVID-19 cases in the community, suggesting both patient and provider preferences for socially distant, non-contact during care surges or during surges of COVID. So if we fast forward to March 2022, we saw that 46% of care was virtual, and a very, very small minority, just a few hundred family physicians were doing exclusively virtual care. So research has been done exploring both the patient's experience with virtual care, and what we see is patients report that telephone and video visits reduce time and costs and are more convenient. Now, we've also looked at administrative data, and what that's indicated is that physicians who provided more virtual care, and this is an important point, did not have more emergency department rates among their patients compared to those who provided less virtual care. So what that means is that ED visits were not correlated with virtual care when that care was provided by their own doctor or their own clinic. But recent unpublished research has found that virtual visits provided by virtual-only platforms, so virtual walk-in clinics, for example, they do correlate with increased ED visits. So as with other studies in non-pandemic time, continuity of care, and we're going to talk about continuity of care a few times, is critical. And during the pandemic, we saw that poor continuity of care and the lack of physical examination might be contributing to increased emergency departments, like I just talked about, by these virtual walk-in clinic patients. Research has found that virtual walk-in patients are both less likely to have subsequent in-person physician visits and twice as likely to have subsequent emergency department visits within 30 days. So the number is actually 8.3% versus 4.1%, so considerably different compared to visits with people that actually see their primary care provider. And so this is really important as we think about moving towards COVID-19 recovery. We need to think about further research and guidelines to think about what is that optimal implementation of virtual care. And OH just released some guidelines that we can share with you. And how do we balance issues related to equity, efficiency, patient-centeredness, safety, and appropriateness? So we know throughout the pandemic, we also have important gaps that have happened in other preventative and chronic disease care. So here we see the gaps in care, and we know there's lots of data that's showing decline in cancer screening rates. Testing volumes are coming back up, but we've got a ways to go, and we need to be really innovative to think about how we can catch up. We need to recognize that the role of primary care looking ahead will be especially important given these high levels of deferred care, long waits for specialty care and diagnostics, and the rise in mental health and addictions, the impacts of long COVID, and just the persistent gaps in health equity, just to name a few. We recognize and stressed in the report that balancing these COVID responsibilities The regular non-COVID care and the COVID catch-up are going to require more resources, as Danielle suggested at the beginning. We did all of this without resources, but we're going to need to ramp them up moving forward.
So switching gears now to speak a little bit about the second part of this brief, which really focused on, Jen has outlined beautifully some of the work that lies ahead, ongoing COVID work, catch up of management of chronic disease, prevention, screening, and addressing health equity gaps. And the question is, what is our capacity to do any of that in the primary care sector in Ontario? The second part of the brief really focuses on health human resources, the data that are available. And I'll stress from the outset that most of the data available in Ontario are physician data. And that's a real limitation that we point out quite strongly throughout the brief and in the lessons learned in part 3. But nevertheless, important data that really shape what will be possible as we consider the big challenges ahead. And so in part 2 of the brief, really the take-home message is that we are in a human resources crisis, which of course has been well covered with respect to hospitals. People are aware that there have been very significant shortages of human resources in hospitals, but indeed that this is also true in the primary care sector. And before we dive into this section, which I will say is somewhat depressing set of evidence, I will also, I think it's worth emphasizing that this is not just a Canadian, it's not just an Ontario issue, and it's not just a Canadian issue, that this is really a global phenomenon. And so although it's important for us to address it and also to name and call out the Ontario specific factors that might be driving and contributing to these shortages and capacity gaps, we also need to acknowledge that this is happening all over the world. And it really is in part a predictable consequence of the many waves of the pandemic that we've all been through together thus far. So where are we at today in Ontario? Well, 1.8 million people in this province do not have a regular family doctor or primary care provider, and those needs are not equitably distributed. And so the equity deserving communities that CHCs strive to serve are indeed overrepresented in that group of people who do not have access to regular primary care, people who are new Canadians, those who live in low income neighborhoods, and others from equity deserving groups. And that number is growing, and it has been hastened in part by the large number of retirements that we've seen in Ontario among family doctors, such that there's been an approximate doubling of the rate of retirement among family doctors in the province. And so it's worth noting that 1.8 million doesn't speak to the additional 1.7 million Ontarians who are attached to a family doctor who's age 65 or older. And so we can reasonably expect that many of those folks will be retiring in the coming years. And I can assure you, as a chair of family medicine at the university, no matter how hard we work, no matter how much funding government gives us, no matter how much expansion of our programs there is, it is not possible for us to train enough family doctors to close this gap in any short order at all. And so that is both a crisis and an opportunity for team-based care. And team-based care indeed was one of the great learnings of this pandemic with respect to primary care, that teams were better positioned to respond to the crisis of the pandemic than solo practitioners. And I will say that this is in no way an indictment of the extremely hardworking solo practice docs out there. I will say, as a resident of the city of Toronto, we know the neighborhoods in which many of those solo practice docs are working and the populations they are serving, and they have worked very hard, and many of them are serving really high needs neighborhoods with none of the interprofessional supports that our colleagues in CHCs are lucky to be able to participate in. But nevertheless, that model has proved to be inadequate to pivot to a crisis of this magnitude. And so group practices of physicians have been more likely to offer after hours appointments, are more likely to use an EMR, are more likely to participate in quality improvement, and teams were better positioned to offer continuity of care, which is important, as we know, throughout the period of the pandemic. And team-based practices were also better able to rapidly mount COVID-specific responses, and that includes things like COVID care at home initiatives, so that the very rapid rise and setup of primary care centered COVID at home models that allowed us to care for patients in the community with COVID-19, as well as, of course, huge amounts of outreach with respect to vaccination and testing and assessment. Teams were better able to participate in those models for obvious reasons, because people were better able to spell each other off for the regular practice of primary care, and the incredible capacities of the interprofessional team were such that nurses, social workers, community health workers, pharmacists, and others were able to take on roles and tasks related to COVID care that, of course, a solo practitioner is simply not in a position to be able to provide.
And Danielle, if it's okay, I'll just jump in with a few slides. Sorry, Catherine, I just can't help myself. If you could just go back for 1 sec. I just, I just wanted to highlight a few examples because they were so amazing. So within all of the team-based models, so within family health teams, CHCs, nurse practitioner-led clinics, we saw such amazing innovation. Early on in the pandemic, I did a survey across all of the organizations that had team-based care, and we saw such innovation and community outreach. So many places, staff members were redeployed to actually do different sorts of things. So they were delivering food. They were connecting with chefs to cook care baskets for people. They were reaching out to people who were lonely or isolated. They were recreating all of their support groups online. They were making sure people were safe on the streets. They were advocating and continued to deliver on-site services for people who needed them, for wound care, for safe consumption. They established pop-up clinics, and some of you may have seen those pictures of pop-up clinics with DJs and people lined up across the street around the blocks. And they engaged with the most hard to reach communities by hiring trusted peers who acted as community health workers and ambassadors. And this resulted in hundreds of thousands of people getting vaccines or getting health care. And this was a result of having those teams that could be redeployed to do that work. And so I think I just wanted to highlight this because I think this was a perfect example how we saw the power of interprofessional teams. They were able to scale up and work in community vaccine centers. We heard of all sorts of team-based organizations actually being charged with setting up those vaccine centers. They ran pop-up clinics. They did drive-through vaccine clinics. So I couldn't let the slide go without doing a bit of bragging about the great work that team-based care contributed to the response. Thanks, Danielle. Sorry for interrupting.
No, it's great. I agree, Jen, and I'll just say it links nicely to what we're about to talk about. I mean, if we, of course, we've always known that team-based care is the gold standard. And in a way, I mean, one of the silver linings of this entire pandemic experience is that we now have lots of additional evidence to support that claim, and many examples as you've outlined to support it. And so, of course, the issue is that not everyone has access to a team. And so, and the next slide speaks to that quite nicely. This slide looks at the likelihood that a person, the proportion of people in every OHT in the province that are not attached to a primary care team. And it speaks to both family health teams and community health centers. The two, of course, family health teams are the most common form of team-based care in Ontario, but it also includes the CHC data. And therefore, what you see on the graph is the high bars are those OHTs or neighborhoods that have the least attachment to teams. And as you can see from the graph, this is also not equitably distributed. So in some communities on the left-hand side of the graph, almost everyone in that OHT. It's hard for me to see the my vision deteriorates as I age. But anyway, I think Peterborough, for example, is pretty far on the left of that graph, where almost everyone in that, almost every patient in that OHT or a client in that OHT is attached to the family health team that encompasses almost every practice in Peterborough. And on the right-hand side are neighborhoods like Scarborough and Mississauga that have very, very few teams for the population that they serve. So there really is a significant inequity, geographically speaking, as well as other forms of inequity in terms of who has access to those teams. Approximately somewhere between 25 and 30% of people in Ontario are attached to a team. And so as we think about those 1.8 million who are not attached to anyone, the 1.7 million whose family physician is on the verge of retirement, and the large numbers of new graduates who are coming out into our system in family medicine who are not choosing comprehensive family medicine, the only answer really conceivably is the team. So all of this occurs then on a backdrop. Next slide, please, Catherine, of this bizarre moment that we find ourselves in now, with one foot in COVID and respiratory surge and another foot in COVID recovery and health system rebuilding. And it is an uncomfortable place to be for everyone in the health system, and most importantly for our clients and patients. But just to name a few of the ways in which the challenges in other parts of the system are being felt in primary care, and all those of us who work in primary care feel these every day. The number of folks coming in who've been disconnected from either our own services or disconnected from their specialty care, who've had procedures or imaging canceled over the course of the pandemic, who've fallen out of touch with their specialist, who've not received ongoing care for their chronic illness, or who've seen a rise in concerns related to their mental health. All of these problems, of course, come back to primary care. And so when the system is stressed, as it is in other parts of the sector, these problems find their way back to the primary care office. And of course, that's what we want. That's our job, is to support people through these kinds of things. But it is a bit of an avalanche in this moment. And one of the things that we learned in the pandemic is that when there is poor infrastructure to support primary care practices in dealing with all of this, those stresses really have an impact on the well-being of providers, and hence the very high rates of burnout. And I'll emphasize again that is an international phenomenon. There was a Commonwealth Fund piece that just came out in the last couple of days about burnout among primary care providers internationally. So this is something that's being felt elsewhere. But I will say, just from my own experience as a family doc in the system, I have never experienced such difficulty accessing services for my patients. And so we're all feeling as though every crack in the system leads people back to us, which does lead one to wonder how it's conceivable for people who don't have a primary care team or a primary care provider to help them navigate the system, how they can really navigate anything at all. We'll move now to the final part of the brief, part 3, which really focuses on lessons learned. And I'll say that, of course, these 5 lessons require some leap of faith and interpretation on the part of the authors of the brief. And we spent quite a lot of time looking at the evidence and debating what we felt were the most important findings of all of this consolidation of evidence that took place. And these are the 5 lessons that we believe are most critical for decision makers and the public to understand about primary care in Ontario. And I'm going to, Jen and I will briefly touch on each one and say a few words about them. So lesson 1. Next slide, please, Catherine. Lesson 1 is that care provided in formal attachment relationships and care provided through teams fared better for patients in the pandemic. And we've covered much of that evidence today. Just to say that there is this difference between a formal attachment relationship and a loose attachment relationship. So there are people in Ontario who will report that they have a so-called regular place of care, a place where they go, and or even a provider who they see, who they is sort of their first stop. But in the absence of a formal relationship, and in our context, that really means rostering or enrollment of some kind, that those formal attachment relationships really mattered in terms of people's ability to be able to continue to access care from that same provider or team through the pandemic. And as we've covered more than adequately, I think the teams fared better as well. And so what is the lesson learned there? We put forward that the lesson learned is that every single person living in this province should have a formal attachment to team-based primary care. That should be the goal. And, we can debate at the margins what kind of team and what kind of community and what kind of neighborhood, et cetera. But the bottom line is the pandemic has reinforced, and we have now more than ample evidence to support this claim, that the pandemic has reinforced that teams do better and formal attachment yields better results. The second lesson is that trade-offs are real. We knew this in hospitals early on, and we've been seeing it actually in our pediatric hospitals over the last number of weeks. It is well understood that when there is a surge of COVID-19 or respiratory-related illness in hospitals, that redeployment of resources needs to occur to meet that surge. So operating rooms closed so that nurses could be redeployed into the ICU, into the COVID wards, into the emergency departments. And that was a choice that we made as a health system. I think, in the moment and at the time, it seemed like the only choice that we could possibly make. But what was less visible is that those trade-offs were also being made in primary care. That in the absence of additional resources, when surges of COVID occurred, people would move over to virtual. There would be an increased rate of COVID care at home and other, COVID-related work. That when the vaccine initiatives were underway and primary care was being exhorted to do everything we could to come out and support the vaccination effort, that other things happened less as a result. And those trade-offs are important to acknowledge. They are real. You saw the data on cancer screening. There's similar data related to immunizations among 4 to 6-year-olds. Happily not infant immunizations, but immunizations for 4 to 6-year-olds and other forms of management of chronic disease. And that might have been okay briefly, but to the extent that this is going to be ongoing, we need to really examine the implications of those trade-offs. Now, Ontario Health has a number of stated priorities for primary care that have been put out there around continuing to focus on urgent care during this respiratory surge, identifying people who would benefit from Paxlovid and early intervention around COVID-19 infection, catching up on preventive care and chronic disease management, continuing to support vaccination. Now, of course, a push for the flu vaccine. Those are all super important priorities, but we're not yet having any conversation about what to deprioritize. We just keep having more conversations about more priorities. And so one of the lessons learned, I think, from the pandemic is that in the absence of additional resources, something is going to fall off the bottom of that list. And so if we want to do everything and more, we're going to have to think about how to resource that.
Third lesson we highlighted, and it's probably obvious from our presentation so far, is we really saw innovative models and new partnerships that help patients, particularly those from equity deserving groups, to get needed care. But again, as Danielle has pointed out, we really need infrastructure because this was not universal across primary care. We also saw the rapid uptick of virtual care. But again, remember from those graphs, we're learning that not all virtual care is equal. We need evidence-informed recommendations to guide primary care clinicians on how to decide whether care should be delivered in person or virtually. And remember, I talked about the emerging evidence for potential harm when virtual care is uncoupled from that in-person continuity of care, as in the case of virtual walk-in clinics. So we know that virtual care can improve access for some people, especially those with mobility issues, those that live in rural and remote dwellings or have restricted schedules. And what we have to recognize is sometimes we also need to ensure that people have appropriate technology or data, Wi-Fi, and ability to use virtual care tools. So we call that digital equity. And it may also exacerbate barriers to cultural safety, including lack of trust, language and cultural barriers. And we need to make sure that we really respect a person's choice of what they want, how they want to receive their care. So some folks that are marginalized may prefer to be able to come in person, which I mean makes total sense. And I think we saw, and we heard some examples from when I broke into Danielle's slide about just really innovative models, but we also wanted to talk about the partnerships that really help people, especially again, those from equity deserving groups, to get the care that's needed. So I'll give you a few examples because I just love them. There were some really amazing examples between health and social services in partnership with primary care. So there was one called Under One Roof Initiative, and this was a partnership of 7 health and social service agencies from the East York region of North Durham OHT. And they had the goal of understanding the health needs of older adults from East Asian and South Asian communities. And what they did is they co-designed solutions to improve equitable, culturally relevant, and accessible primary care for older adults. So this was a new partnership between these agencies. And again, I talked about this earlier, but there was a Black vaccine engagement team, a consortium of 10 Black community serving agencies. They came together in April 2021 to encourage the open, culturally responsive, non-judgmental engagement and education of Black residents from across Toronto around COVID-19 and the vaccination. We've got another example called Operation Remote Immunity. This was a vaccination effort that was a collaborative effort between the Anishinaabe, Aski Nation, the Ministries of Health, Indigenous Affairs, and the Solicitor General and Natural Resources and Forestry. So kind of strange organizations that all got together. And in total, over 42,000 vaccine doses were administered through Operation Remote Immunity. We just wrote a paper about a community ambassador program that 11 primary care organizations were funded through Public Health Agency of Canada. By partnering and working closely with those community members themselves, they were able to increase trust, vaccine confidence, and administer close to 20,000 vaccines. So I think this is a really important lesson learned, that we can collaborate across the sector, build new partnerships, and really provide access to care that might otherwise be not available. The fourth learning that we really highlighted was that there was an absence of integrated and inclusive data. We've seen this throughout this presentation. So we were unable to talk about nurse practitioners because that data is absent from the administrative data. So in Ontario, as most of you know, we do not have a complete picture of primary care in the various administrative health data sets, which we use so much for this paper and which we use all the time in measuring and understanding healthcare. So important aspects of care are not included. And people that know me know this is a bit of my mantra, because care such as the provided by non-physicians, so all of the teams that work within family health teams and nurse practitioner-led clinics are not included. All of the care provided by nurse practitioners are not included. Now within CHCs, of course, we're able to include all that. We've got our team-based data, we've got our nurse practitioner data, and we've got our physician data, but that's it. And so the 30% of folks that receive care from other team-based models are invisible, except for the care they receive from physicians. Across Ontario, patient-level sociodemographic details such as race, ethnicity, immigration status are often missing. Again, in CHCs, we collect it, and we saw how important this data was. By looking at this data, we can identify gaps in care and disparities in health outcomes and quality of care. So you might remember those maps during the pandemic that showed huge disparities of care, huge disparities of who was getting COVID and who wasn't getting COVID. We need to have that data. So we need to strengthen data collection. We need to strengthen governance. We need to strengthen oversight and use for an equity-oriented system response, as well as quality improvement in research. We need to understand those disparities in health outcomes. And finally, data from primary care should serve as a critical piece of a provincial data platform and inform health system response to future pandemic waves and just overall population health. The fifth lesson we highlighted was that primary care can and should leverage its longitudinal relationship, because that's just inherent in primary care. We serve people on all aspects of their life. And as Danielle said, people keep coming back to primary care. This will ultimately improve population health and health system sustainability. Primary care is also a critical communication channel. We've got those trusted relationships with the clients and within our communities. And when primary care came together as a sector to learn, exchange information, and link to other parts of the health system, we saw it worked. And just a couple of examples that are, again, super cool and super innovative. We saw a pandemic pregnancy guide. This is a group of physicians that started an Instagram page that dealt with issues around what to expect when you're expecting or parenting during a pandemic. And what happened on this site is physicians offered reliable information, and they had over 40,000 Instagram followers. Another example was COVID vaccine facts, another Instagram page started by physicians throughout Canada. And they answered questions about, people just navigating through the pandemic, questions that came up. Again, over 6,000 Instagram followers. And I think this speaks to the trusted relationship that people have with their primary care providers, but also understanding that the credibility earned through these trusting relationships can be leveraged for COVID-19 recovery and future health system crises. We did it through mass communications, but we also have these one-to-one relationships that we have with our patients every time we interact with those folks. So something to leverage as we move forward.
So as we come to the end of our formal presentation, we just want to point out that, everything leads back to what we've always known about primary care, which is, the so-called 4 C's, the Starfield 4 C's of primary care, which are first contact. So primary care serving as the first point of contact for people in the system, continuity, coordination, and comprehensiveness. And the recommendations in this final part of our brief really come back to those, to say that the evidence from the pandemic is consistent with what the international evidence over decades and decades has shown, which is that continuity of care is important, and that it is best provided in a formal attachment relationship by a clinician who is supported by a team. The primary care needs to be set up to be able to coordinate care in this highly fragmented time that we find ourselves in, and that means that there will need to be infrastructure support for coordination, whether that's ensuring that access to services like specialty care and advanced imaging are done in a way that is coordinated and makes sense, so that you've got single entry models, single types of referral forms, clear paths for people to get in and out of specialty care, good communication back to primary care, and good coordination of communication, as Jen has pointed out. And so that coordination requires investment in infrastructure so that people can get information and provide seamless handoffs throughout different parts of the system. And finally, comprehensiveness. Comprehensiveness has never been intended to mean that a single individual healthcare worker should do all of the things for all of the people all of the time. It always has meant that primary care as that first point of contact should be a doorway into the other parts of care, whether it's health or social care that a person might require. And again, that is best done in team-based models with proper infrastructure support, with appropriate data, and with clear pathways in and out of the other parts of the healthcare system that our clients and patients need to be able to access. Those recommendations and more specifics related to each of them, with lots of examples of the kinds of things that would support continuity, coordination, and comprehensiveness, are found in that third part of the science table brief. And so if you have an interest in reading a little bit more or understanding some of the data sources, we'd invite you to visit those, to visit the COVID-19 science table website. And I can put the link into the chat for everyone so you can peruse those at your leisure. And people have asked about whether the slides will be available. And I think the answer is yes. And I know that Catherine will know how to get those to folks. And of course, the webinar has also been recorded. So this brings us to the end of our formal presentation. And I'm pleased that we've left lots of time for interaction and discussion and invite people to put their questions into the Q&A. I know Jen and I will be happy to take them. Thank you all for joining us this morning.
Thank you so much for your presentation, Jennifer and Danielle. And we do have a couple of questions that have come in the chat already. So I will pose those to you as other people are thinking and typing. The first question comes from Marnie, and she's asking is it time to have formal catchment areas for primary care groups with patients and families assigned to local primary care groups?
Do you want to start, Jen, or do you want me to start?
Sure, go ahead. I'll jump in.
I do think that this OHT experiment will head us in that direction. And some of us who've been around a while will remember the Price-Baker report, in which we compared access to primary care to access to public schools. You know, the notion that when you move into a neighborhood, nobody says to you, well, there's no school accepting children in your neighborhood. Your child immediately has the right to attend the local public school. And so this notion of families or group individuals having immediate access to primary care in their neighborhood or their region makes sense. Two caveats to that when it comes to primary care. The first is, of course, in order to do that, you've got to have the capacity to take folks on. And that's not easy, as all those of us know who grapple with waiting lists and that 1.8 million number that keeps me up at night. And so simply telling groups and individuals that they have to take on more people will set us up for people who, for attachment without access, which is not really very much better. And so I think we have to be careful about that. If we're gonna say that people have a right to attachment within their catchment area, we have to make sure that we've got the capacity to do it. And the second caveat is that there is hot debate about what do you do with an existing relationship. And so if a person, I've got patients who come back from Ottawa to see me in Toronto. I'm sure they like me a lot, but those folks would much rather have a family doctor in Ottawa. But, if a person moves from Scarborough to Jane and Finch and wants to maintain their connection with their primary care provider or team in their original neighborhood, how hardcore do we want to be about catchment areas, particularly in a place like Toronto and in our big cities where there is so much mobility and movement around. And so those things have to be balanced. But I do think we are headed in that direction.
And I'll just jump in. Within the community health center model, we look at population health in sort of the bigger community. So often the folks we serve are part of the community as well as the people who walk in the door. And this is just the way they're built. So they're built on sort of that big comprehensive definition of comprehensive primary health care. So they often employ community health workers and health promoters who actually try to build a healthy community. So I think, when you think about a primary care office being nestled within a community, if they again, if we embrace that team-based model that included folks like health promoters, community health workers that could work on building safe spaces, healthy, green spaces, it'd just improve a person's access to healthy spaces. And I also wanted to stress that with working within a community like that, we've got projects on within AFTO and the Alliance for Healthier Communities, where we actually work with other primary care models to ensure people have access to teams. So this is called team care. And we want to ensure that folks have access to team-based care or social prescribing. How do we do that? We work within our communities to make sure people can access the right care. So I think that's sort of a utopian version because of all of the hurdles that Danielle mentioned, but I feel like ultimately that would be an amazing picture if we could get over the other hurdles.
Thank you. And the next question comes from Brent. It's maybe a bit more of a comment than a question, but Brent notes that historic policy decisions around physician remuneration have had significant impacts, and this is demonstrated in the report. Some examples that Brent cites are the limitation of joining FIT by new graduates only to areas that are deemed underserviced, much lower pay for physicians employed by CHCs, and very poor rollout of fiscal supports for EMR use. So given that at present the hospital sector is the biggest player at the funding table, when will the leaders of healthcare make the needed philosophical and ideological policy changes? Now, I don't know if either of you can really answer that on behalf of the leaders of the healthcare system, but maybe you have some comments on that.
I mean, I certainly can't answer it on behalf of the leaders of the healthcare system or hospital sector, but I might offer a few additional observations on this theme. The first is that coming back to this conversation about OHTs, that, you know, I do believe that our hospital colleagues and our leaders in hospitals understand, perhaps now more than ever, although memory, you know, is often short, but now in this fall respiratory illness surge, understand more than ever the critical importance of primary care and the degree to which poor access to primary care leads to a demand that simply cannot be met in the hospitals, whether that's emergency departments, visits for people who don't have access to a family doc or a primary care team, whether that's admission to hospital for poorly managed chronic disease that has led to a crisis point, whether that's people who are stuck in ALC beds and can't be discharged home because they don't have appropriate supports in the community. Like, the hospital CEOs get it, that this is important. And also, as we know, the urgent always trumps the important. And so it is very difficult to actually move resources according to that understanding. And I think that that's the challenge we've always had in primary care. People have been talking about moving resources out of hospital into community for, decades and decades. But, it doesn't happen because it's super hard to do when you've got a long waiting list for urgent neurosurgery. We all get that. It's very, very hard to move resources in that context. And so OHTs offer perhaps an opening for that conversation about moving funding around. And also I worry that the backlogs for procedural issues and specialty care could once again elbow out this conversation. And given that the hospitals, as you pointed out, are always the loudest voice at the table. So I don't have an easy solution to that. Like, these are really difficult problems. I don't think that there is an absence of understanding among system leaders and hospital leaders about the importance of primary care. The final thing that I will say on this, and then I'm sure Jen will have some comments, is that it is very easy for a conversation about why primary care is important to quickly disintegrate and devolve into a finger-pointing conversation about that primary care isn't doing its job in some way. And we have heard echoes of that from health system leaders and hospital leaders over the last couple of months, and it has been very damaging to the morale of our colleagues who, as you've seen from the evidence, have been working more consistently for a really long time. And so, I don't have an easy answer to that one either, because it seems like every time somebody realizes that primary care is really important, it's immediately coupled with a false narrative around, and if only, if only the family doctors would work harder, then we wouldn't have full emergency departments. And that is a really, in this moment where people are burnt out and feeling underappreciated and undervalued, it's a killer to our sector. And so we need to do all we can to push back on that narrative with the evidence that we've got. And that's going to be a really important challenge. I would just invite everyone on this call to look for every opportunity you have to be clear about the fact that primary care workers of all kinds in all models have been working harder over the course of this pandemic than ever.
And I'll just add, and I know we're at time, but I think I've done jurisdictional reviews around the world, and every integrated healthcare system that works has a strong primary care foundation. Decades of data, and Danielle pointed to this, show that health systems with strong primary care sectors are achieving better population health, health equity, efficiency, quality of care, and cost reductions. So it's all the stuff that we want to achieve with OHTs, but we need to build that strong primary care foundation. And I think we've got a willing sector, but we need to infuse some resources in it to do it properly, to ensure people have access to comprehensive primary health care, because we know it works. We see it around the world.
Thank you both. And you're right, we are at time, but there's a couple of questions that I want to quickly get to. One, actually, I think, Danielle, you're answering Michelle's question about what we need to measure and how to protect data, both security and access. And I think maybe your answer we can share when we share the slides and video afterwards. And the other question that I'm going to just ask is, if an established team has an opportunity to expand, who or which organization should they advocate to for resources to support that expansion? And do you have any advice to share on the best approach?
Well, I think the Alliance and AFTO, or both an END and PALCA, are working on a paper, a policy paper. So I think get involved with us, and we'll help advocate with you. I mean, I'll of course work with your ministry branch, work with your OH folks, work with the OHTs, work with your partners. We saw the power of partnerships, but I think we're also working together as the primary care collaborative to really advocate for team-based care. It's going in for the budget submission, but Ravine, I don't know if you want to jump in, but we've got this policy paper that we're writing to build a case for increasing team-based care in Ontario.
Thanks, Jen. It is 8:49, so I think we will, in respect of everybody's time, we'll wrap here. But I want to thank Jen and Danielle. Thank you both so much. And thanks to Iman in absentia for her work as well in helping to build this slide deck. So just one final reminder to everybody, this has been recorded, and we will be sharing the slides as a PDF and the recording on the Alliance website, and everybody who registered will be getting an email with a link to that. So thank you, and I wish everybody a great day.